Good evening and welcome to Cafdil Healthcare on Cafdil Television. My name is Kojo Arthur. Tonight we are going to have a very important discussion on emergency because we are celebrating World Emergency Medicine Day. And so it's very imperative that we understand what goes on at emergency when we visit hospitals. Some of us, we don't understand what goes on there, and so when we go and there are certain things that we don't understand, so we tend to talk much about what goes on there. So tonight they are going to help us to understand exactly what we should be doing when we visit hospital emergency. We are live on Facebook, Cafdil Cape Coast, and on YouTube, Cafdil EDU. My guests are seated already, and I will introduce them when we come from break. Stay tuned.
Since time immemorial, God has always communicated himself and his will through various voices: the prophets, the kings, the judges, not forgetting John the Baptist, who was a precursor to Jesus Christ and gave us the will of God. We bring to you Voices from the Valley. This is a program designed by the Conventual Franciscan Friars in Ghana in collaboration with Cafdil TV to bring you in-depth insight in our faith, catechesis, and various Catholic teachings which will help you in your journey as a pilgrim. I know you cannot miss this program, and I highly encourage you that you shouldn't miss this program because it is Voices of God from the valley of prayer and silence. Join us this and every Sunday at 3 p.m. and a repeat on Wednesday at 7:30 p.m. here on Cafdil TV and on our various social media platforms: YouTube, Cafdil EDU, and Facebook, Cafdil Cape Coast. Let us meet and share what God has for us through the Voices from the Valley.
Lord, make me a means of your peace.
Welcome back. If you just joined us, this is Cafdil Healthcare on Cafdil Television. My name is Kojo Arthur, and we are talking about emergency medicine. In fact, what emergency medicine means. So that is exactly what we're going to talk about. I have my guest tonight from Cape Coast Teaching Hospital, Dr. Papa Kojo Mbro. He is emergency medicine specialist and also head of department, emergency department, Cape Coast Teaching Hospital. Welcome, Doctor.
Thank you very much.
And also Dr. Matilde Emisa is a medical officer, emergency unit, CCTH. Welcome.
Thank you.
And Mrs. Evelyn Bauer Aisen Arthur, my namesake anyway, emergency nurse specialist, Cape Coast Teaching Hospital. You are welcome.
Thank you.
All right. Normally they say ladies first, right? But itu tua is Ibemabu. Doc made mention of it, so I'm going to start with you. We hear the term emergency medicine, including myself and our viewers. We don't really understand what is it, and so I want you to help us explain exactly what emergency medicine is and what does it involve actually.
Thank you very much, and good evening to your listeners. Emergency medicine is a branch of medicine that specializes in the management of acute illnesses and injuries in all age populations, and we pride ourselves to be specialists in undifferentiated cases. What that means is that when the case comes to the hospital and we would not know whether it is medical or surgical, the person you want to see you is the emergency medicine specialist who will be able to identify whether you belong to the medical, surgical, pediatric, obs-and-gynae. Then we call it disposition. We dispose you properly to be seen by the long-term caregivers. So essentially, that's what emergency medicine is about.
Oh, okay. So what type of conditions are treated in the emergency department?
So we treat a wide range of cases from the very worst cases to the minute emergencies. So the thing is that in the emergency department, we have two perspectives to look at it. We have the patient's perspective and then the practitioner's perspective. For the patient, an emergency will be anything that they've perceived to be life-threatening that makes them come to the emergency department. Whereas when you come to us in the emergency department, we have been trained to segregate your emergencies into a spectrum of severity by means of triaging. So our response to your emergency would depend on how we categorize your emergency, whether we see you rapidly or you delay a little bit before we see you. But before we even proceed, I would like to say that in emergency, different from the OPD where there's a queue and then you're seeing when it's your turn, that does not work in the emergency department. In the emergency department, we see you based on the severity of your illness. The sickest person will be seen first, and the less sick person will be seen later. And it doesn't matter how long you came. If you're waiting long, it means you are safe to wait long. If you're being seen fast, it means that waiting is going to be detrimental to your life, and therefore will do so. Many a times, people come into the emergency department, they see themselves to be waiting and seeing other people going in. The simple reason is that the person going in is at risk of dying versus you who is not going. And maybe our communication may not be the perfect way we communicate to our client, but that's exactly what's happening.
That's why normally the patient intend to say you are taking care of the sick for neglecting the here for.
Yes, but then they see,
they see that.
Exactly, but as I've explained, it's very difficult for it to be so.
Okay.
Because our mind goes to treating the illest person first, and then we see the next people differently, separately, and at a separate time. But the patients who are coming will always perceive their emergencies to be red emergencies. But unfortunately, we may triage them and notice that maybe you are on the lowest spectrum of the emergencies, and so you will not get the attention you expect to get. And that usually leads to some confusion at the emergency department. And that's why we are here to see how best we can throw some light onto how the processes work in the emergency department. Hopefully, we'll be able to help them to understand the processes.
So when you come to emergency, you have a team.
Yes.
So who makes up the emergency care team?
So the team is made up of everybody, both clinical and non-clinical personnel. So when you're coming to hospital, the first persons you may meet will be the security guys. They are the ones who are mostly abused by
the
people
security at the hospital.
Yes. So because we're talking about the emergency, we're talking about the emergency security. We have a separate emergency security for the emergency department. And the emergency becomes a high risk area, especially when we have overcrowding, when we have mass RTAs. We have patients who are aggressive, abusive relatives, and patients who are behaving differently based on their illness alone. And so we need a security man to help us to create some order. Lack of that order will lead to chaos inside, and therefore it becomes very imperative to at least listen to the security man who has been working with us and literally works on our instructions to help us control the crowd and allow us to do what we do best inside. The next people at the emergency department will be the porters. The porters are the ones who will come and pick you from your ambulance or your car if you are incapable of walking and bring you inside the
Those people are trained to do that.
Exactly. So you're trained. Not everybody should be carried anyway. So they've been trained to know how to know when to use a wheelchair, know when to use a stretcher, know when to allow you to walk with assistance, etc. So those are the second people you will meet. The next people who are working with us in the emergency department are the cleaners. They are the ones who keep our infection and cleaning of the place up to scratch, trying to clean the washrooms, the bedsides, the beds, etc. We have the records people who will take your registration when you enter to key in whether you have health insurance or not having health insurance. And then we have the accounts people who take care of your money. We have the pharmacy people who take care of medications. They'll come inside the clinic. We have doctors, we have medical officers, we have specialists, emergency medicine specialists, we have emergency specialist nurses, we have general nurses also in the emergency department. Because we're teaching hospital, we also will see that there will be students in the emergency department, there will be other teams.
Students, doctors,
students who are in school, so nursing students, medical students, psychology students, all the medical fields come around to come and do the rotation there. And then we also have the definite treating team. So if you internal medicine specialists will be coming there with their team, surgeons will be coming there with their team to come and review the patient that we have first stabilized at the emergency department to decide on whether they are going to the ward, whether they are being discharged, or whether they are going to theater or somewhere like that.
Which means a lot goes on there.
So the emergency department is not just the doctor or the nurses. The whole body comes together to form the team that work together to keep our patients safe in the emergency department. Any one of them, when not available or not functioning the way that they're supposed to function, will lead to some mishap happening in the emergency department. So we'll all work together as a big team and we respect ourselves accordingly.
So why is emergency medicine considered a frontline specialty?
So I like to always make this analogy. When the soldiers are going to war, they call all the they call battalions.
Yes, you have battalions.
Yes, but then there are some
regiments.
special forces. Okay. When the matter is hard, you go and have a meeting and you pull some 12 people and tell them go and capture Osama bin Laden. So we are like the special forces of medicine. When we are the ones,
you go there.
We are the ones who pull you from the valleys of the shadows of death. When things are going very bad for you, we are the ones you want to see. And when you perceive things to be going so bad for you, are the ones you want to believe when we tell you things are otherwise safe. So calm down. Don't be overly anxious. So we are that kind of a specialty that serves medicine in a particular way.
All right. Let me come to
about being frontline.
Okay.
So when you come to the emergency department, and when you come to the hospital, there are two entries, through the OPD or through the emergency department. If you recall, when COVID came, everything hits us first before we're able to inform the rest of the people. So we are in the red zone. If we break, the whole system breaks. So we'll try and hold the fort as strong as possible and then keep other people within the medical space as sane as it can possibly be.
So CCT, you have two gates.
2 gates. It depends on what you call gates.
So I heard.
2 entries.
2 entries.
So for you to enter the hospital, you're either entering through the OPD or through the emergency department. Yes.
Oh, okay.
So you cannot just walk to the hospital.
Is every hospital only CCT?
So every hospital has OPDs and emergencies. They are the usual entry points. Okay. So the OPD we have specialized OPDs where you're going to see a cardiologist, endocrinologist, and we have the general OPD, also called the polyclinic, where general cases go to. So when you are in the house and you feel a little unwell, rather than coming to the emergency department to come and join the overcrowding, you would like to go to the polyclinic. Okay. If they assess you and think that based on your vitals they've checked, you should come to the emergency department, they give us a call and then transfer it to us, where we do the things we do best to keep you stable. But everybody knows that we are the ones who keep people stable. When you are trying to run away from earth, we bring you back to earth. You don't want you to go and see God early.
Dr. Matilda,
yes.
Your departments are often the first point of care during what you call critical situations.
Yes.
And so how important is emergency medicine in saving lives?
Thank you for the opportunity you have given to us to explain this. Okay, so with emergency, it's very, very important, as my colleague doctor has mentioned. It's very, very important because we stand in between life and death for everyone that comes to us as an emergency. So if we say that your life is very important, then we stand in that gap to make sure that you stay alive. That's why it's very important.
Okay, so then share with us some examples of emergencies where rapid interventions, makes the difference between life and death.
Yes. So, for example, the very things we see, like trauma. When a person comes and is bleeding severely, if we don't intervene, stop your bleed, you may bleed to death. So, if we're able to see you early, bandage your wounds, do everything that we have to do, you will be able to save you in time, as compared to, you are in a queue and then you bleed out. That's a very good example. Another example is a stroke patient, or heart attack. So these are very critical cases. If we don't see you on time, you may end up having long-term effects on these illnesses. And that's why it's very important that we see you first, make sure that we intervene as quickly as possible to prevent this long-term effects.
And so you have what you call is it golden minute, golden hour?
Golden hour rule.
Oh, okay. So why are why is this so important in emergency care?
Okay, so with the body's dynamics, I mean, everybody in the way, I mean, their body is, but we talk about the golden 1 hour in terms of being able to save you in a time where your body is compensating. When we say compensating, that is how God has made it, that your body should be able to compensate when you are critically ill, acutely ill. And after that timing, I mean, your body decides to give up. Okay, we have tried enough, and this is time that, I mean, we are giving up. But we want to catch the point where your body is compensating for, I mean, whatever has happened to you. An example is a trauma I have mentioned. Okay, it's a very clear example. If you start to bleed, your body starts to work for you to keep your blood in, or maybe clotting, something we call clotting. It can help you, I mean, reduce the amount of bleeding. There are certain things that your body will do for you, and within that hour, this is what we want to catch, and then help your body to, I mean, recover from that. But immediately your body starts to go, I mean, we are tired of trying to save you. That is where everything becomes chaotic, and it becomes very difficult to save a life, especially when it comes to trauma. Yeah.
So then, how does emergency care improve, survival during accidents, and the stroke that you made mention, the heart attack you made mention of, severe infections as well, or even childbirth emergencies? How does this emergency care improve survival of all those things that I've mentioned?
So for all that we are talking about rapid intervention. Okay, so for all these diseases and states that we have mentioned, we are talking about rapid intervention. Okay, so if we are able to catch your illness, we're able to identify, like we mentioned, we triage, and all these things gives us a clue that you have come in, you're a red case. When we say red, it means that immediately we triage you as red. Whatever we are doing, we have to stop and attend to you. It means that in the next few minutes, red is fire. Like red means that we have to stop whatever we are doing and then intervene. You get it? So it comes down to the triaging. When we're able to catch your body physiology in that red line, whatever we do, we stop and then attend to you. In the same way, we have orange, we have yellow, and it goes down to green. But immediately you are in the red, in the orange, your own body physiology will give us that clue. So we have that standard, and that is how we're able to pick your emergency and then try to send you back to the state of stability.
Yeah, all right. But I will come to you. But before that, let me come, because you are the HOD. So I want you to help us bring the conversation home. So I'm talking about Ghana's emergency care landscape currently. How does it look like?
So it comprises of several teams. So emergency medicine became emergency medicine after the May 9th disaster, if you recall.
Yeah, 2000.
When the Accra House of Folks and Kotoko had yes. And when that happened, we became as a country aware of the lack of that care that was needed to save the people who were there's life. That's what birthed emergency medicine in Ghana.
So does that mean before 2000 we didn't have emergency specialists, that kind of thing?
No, we did not have a formal training for emergency medicine. So all doctors were working in emergencies, but we did not have emergency medicine specialists, which will be doctors who have gone to school solely to train on how to see people when they are in these states. Working in the emergency is a little different from working in the quiet OPD. It's a lot of chaos. You need to move from one, unfortunately, dead patient to another patient who is about to slip off and do all the things you know how to do to make them stay. It takes a lot of mental strength. It takes a lot of knowledge and skill to be able to stand in the storm when everybody else is running away to try and bring some normalcy. The scope includes the emergency EMS people, emergency medical technicians, who are supposed to take care of the pre-hospital activities. If something happens to you and you're not inside the hospital, they are supposed to be the ones who will identify your location and bring you to the hospital whilst rendering some care in the ambulance till you arrive at the scene. And we have when it comes to hospital, we have doctors, nurses, we have Red Cross and stuff like that. They all make up the cycle. All hospitals have dedicated space called emergency department, or mandated to have by the emergency medicine guidelines we use in Ghana to have a space specially made for seeing emergency cases. This is supposed to bring us closer to emergencies and allow us to use the skills that has been taught us to segregate our patients into the levels of their severities and then bring them into us. And that's the hospital part. Second part is our patients. Our patients have their own perception of what they call emergency. Okay.
I remember hospital emergency. Emergency because blood will flow.
Yeah, so whilst we have learned how to see emergencies and we understand it, emergency to the patients coming to us is anything they perceive to be life-threatening. And so they'll come to you very anxious, telling you they have emergencies. And then they'll come to you and, like Matilda said, you use the tools that you have available to assess their physiology, determine whether you are in this state or you're in that state. And mind you, the tools you are using have been validated, which means that they tell us the truth when they tell you you are unstable. Sure. And they tell you the truth when they tell you that you are stable. And so we believe in the science and follow the science to see our patient in that particular spectrum. And this has helped us because as Cape Teaching Hospital, our mortality rate for the past 4 or 5 years has been less than 3%. That's a very
less than 3%.
Deep. Yeah, that's a very good achievement. If you compare the statistics to other teaching hospitals, don't say they're not working well, but I'm just saying our number is near perfect number.
I mean, people with critical conditions.
Yes, but we have emergencies everywhere else. So we have Kolebu has an emergency, 37 has emergencies. You can, if you have time, you're a journalist, you can go and find out what their mortality rate is. I'm just letting you know that ours is 3%, which means the contrary to the fear people have that, hey, I'm coming to interbeting, and we probably are saving a lot of lives at the emergency department. Or, like I said, all of them hit us, but then we managed to make sure that very few people go through, which means the system that we have put in place to save people is actually working. And so we will expect that people will believe that we maybe know what we are doing, and so when they come to hospital, they should trust that they have come to us and we are capable of identifying who is in trouble and render that care, irrespective of your financial status. Irrespective of your financial status. And I dare to say that in this our hospital, we practice what is written in the book. That is that if you came to the hospital and you're a human being and you don't have money, we'll still see you with all the resources that are available in hospital. The emphasis is available in hospital. If it's not available, you cannot go and tell you to go and do something that's not in the hospital on hospital's bill. But insofar as it's in the hospital, all our hierarchy knows that within 48 hours, we will do for you what we would have done for you if you had money or not have money, to try and save your life, including doing advanced investigations like CT scans, etc. Only because you're a human being, only because you are a Ghanaian, and only because you have entered the emergency department. We'll do for you and look for your money later. 3 years ago, someone came to the emergency department, no money, no relative, cardiac arrest. We saw a clot in the chest. We needed a drug that costed 18,000 cedis. Guess who used their money to go and get the medicine? Yes. And guess whether they paid or they didn't pay? They have blocked my line. I'm just saying this because whether you are paying us or not paying us, what you're supposed to do, our focus is not about the money. Our focus has always been to try and buy you that time, if it is possible to buy you that time, using the resources that are available to us.
I hope you are not following it, the money. I mean 18,000.
18,000. If I get the money, I'll take. But they blocked me, so I can't follow it now. But if I find them, I'll get my money.
18,000 is peanuts.
People think that we have plenty of money, but then one day we'll have money conversation later. So the point is that, so you see, the focus has never been about the money. And we are I'm sure over the past few months, you have noticed all the issues people are talking about in our health system. We are inside it. We know how to hold your hands and move you smoothly through So when you come to the hospital and we are asking you to pass here and pass here, we know exactly how not to make you slip. Exactly.
Yeah.
You may not like it, you may not have enough time to communicate with you because, like I said, our emergency department has 15 beds, but we see about 10 to 12,000 patients every month. What that means is that every day we are seeing close to about 30 patients on a 15-bed capacity ER. 100% of the time our beds are occupied. But we see you move to the ward, see the next person move to the ward. It's a very chaotic environment. So we do our best to try and communicate with our patients. We post things on the wall for you to come and watch. The triage numbers are on the wall for you to, those who can read, to read. We have a TV there that communicates about the processes that you are supposed to pass through when it comes to the emergency department. And sometimes we talk to patients, but I will always admit that our communication can be improved. So we are always, as human beings, working on how we will communicate to our patients who come to us. But then we try our best to do what we must do. Once we get the feedback, we will always go back and see how we can communicate to our people well.
So how accessible are emergency services in Ghana?
100% accessible to any human being who is able to come to the emergency department, whether you have insurance or not insured. That's what I mentioned about that 48-hour rule. It is stated in the National Health Insurance Guidelines. It's also stated in our National Accident Emergency Guidelines that so far as you're a human being and it comes to the emergency department, we will render the care to you, bed or no bed. We will render the care to you.
Money
and then
or no money.
Yeah, money or no money. And we'll talk about money later. We have social welfare system. Within the first 48 hours, trust that we'll be the one fighting to get the things you need if you don't have anyone. But if you're relative around, we will allow them to do what they must do. But if you don't have, you will see we will be the ones fighting on your behalf, making the calls to all that need to be called to secure the things that need to be done for you, including feeding you. They have fed people for months. Sometimes the nurses use their own money. Sometimes we use hospital means to get food for patients. So money is never a reason not to come to the emergency department. But then as human beings, as we all are, if you came to the emergency department and you are sane, and you say that you want to go, despite you knowing that you are not safe to go, we're not police station. We'll allow you to freely make the adult decision. But if it's for a child, then we'll inhibit you from putting the child in harm. So although you say, I don't have money, I want to go, the answer will be no, we'll not allow you to go. We'll now escalate for the government to see how they can help us. So that's exactly how accessible the emergency department is to all Ghanaians and all the people in the community.
So
as teaching hospital though, we hope that cases are seen as lower levels. If I say lower, that doesn't mean inferior.
Okay.
There are hierarchy of health systems. Yeah. Teaching hospitals seems to be on the hierarchy, top of the food chain. That's where all the specialists and sophisticated environments should be to help us to see complex cases. We like to leave that space for very bad emergencies to use the skills that is available in the department. We don't want to be flooded by cases that can be seen in a district hospital or a regional hospital. Otherwise, that space we're talking about becomes unavailable for someone who may need a referral coming in. So we like for you to see, and then we would like to see more referrals coming to an end as opposed to walk-ins. However, if you walk in, trust that we are going to see you as well.
So, so from what you said, 2009 to date, 2009 to 2019, 2019 is 10 years. To this, how many years since the emergency specialist?
17 years.
17 years.
About 17 years.
So I want to know what progress has Ghana made in emergency medicine over these years, this period?
Stark difference. Starting from my own house, I have said it's already, our mortality rate is 3%, which means it wasn't 3% before.
Sure.
That's a win for emergency medicine.
Okay.
And we are here today because she's an emergency nurse specialist. She's a hopeful emergency medicine specialist, medical officer.
We were not having them.
Exactly. And then their usefulness is showing in the quality of care received in the emergency department. I don't know how many of your viewers have come to interbeting before, but interbeting 10 years ago is not the same as interbeting today.
Yeah.
So that change is happening real, and it's very visible and evidenced by the statistics that we are able to
face.
Most
of us, didn't want to go to interbeting because Sayana was Ufi. Bakan no kind of intervention, which means you are not coming home again. So most of us didn't want to come to intervention.
So the problem is that as so far
then. No?
Yes. No, I mentioned to you that we are special forces. When things are very bad, that we'll be the ones there to help you. But then at the same time, we're not God.
Yeah, sure.
Which means that if you don't come early and you come late and your body has already failed, there's very little we can do to help. So most time, because we are a referring hospital, would have gone to other places and received care, and then they'll bring it to us when things are at the we are crossing over. And that's where we try to put our effort together to see if we can. But if a body has failed, it has failed. There's usually nothing you can do. And sometimes there's some illnesses that no matter how hard you pull, you cannot do anything about, like stroke, like a very bad bleeding in your head. Irrespective of where it happened, there's nothing we can do. So that's where we come in, doing some of these things to educate people on how to prevent themselves from getting this injury. And also assuring them that if you get injured, come to us early. Don't go to church and pray first. Come to us first and let them pray for you in the house so that we can get the time to. God also gave us some wisdom.
Sure.
We can use our skills God gave us to try and see how best we can help you.
Certainly, you're going to have some challenges.
Yes.
And there are certain challenges or some. So, what is the biggest challenge the emergency department, it faces?
So, our challenges are usually his. Our nurses are the ones who faces most of the challenges. They can tell us. So, let's senior nurse tell us some of the challenges we face in the
biggest
department.
one that you face.
Okay, so thank you for the opportunity and good evening to your listeners too and your viewers. Okay, so most of the challenges is with our resources that we work with. So we don't have it in numbers, and the few ones that we have, because the pressure is so much, they easily break down, or they often break down, and we need to get replacements for them. And another challenge too is how our stakeholders, the patients and the patient's relatives, how they flood us when we have emergency cases. So they come and, the space, we don't have that structure-wise, we don't have that big space. So when they come in their numbers, they rush to us, they flood us, and we understand it is expected because, for example, if there is an accident or maybe you are in the office and you hear that, oh, your mom, your dad just collapsed. But even before you could say, Jack, you are there, and they will call your other siblings and everybody will come. And when we come to, we are on you. And to the point that some of us want to even dictate to the healthcare worker or the nurse. Even when you are even applying BP cap, do it this way, do it that way, and all that. So it kind of they kind of come into our space, and it makes it quite difficult to work within that space. And aside that, today, it also even intimidates us. Verbal abuse. Look at the nurse, look at the head, look at the shoe, look at the dress, and all those sort of things. Yes. And it's, you are wearing a shoe, but somebody could be very critical and look at your shoe and realize that we should wear saffron and use it to intimidate you and all that. So we say that they shouldn't. Sorry about that. So they shouldn't intimidate us. And when they come into our space, they should give us that free space to be able to deliver the care that they are looking for. And again, our security. So if you come and you want this thing, and you want to be safe, like you want your patient to get the care that they are looking for, but at the same time, you see some people, they will take their phones, they are recording us and all that. So it doesn't make us safe. So our security too is also.
But you have an emergency security, as the doctor said.
Yes, we do.
Make sure that phones are not allowed. You can also write it.
They can, but sometimes they can be overwhelmed. So imagine a situation where we have a mass RT, which we have often. Mind you, I mentioned that our emergency is supposed to be taking 15 patients.
Sure.
But every day we see close to about 30 patients. So imagine you are in that already full capacity of taking about care of 30 patients. They'll bring you mass RT. The police will just bring them in unannounced. We have 30 new patients. When the place is already occupied, they usually will come with crowd.
Sure.
Whilst you are working inside, the guys will be abusing the security man, and some people come to the hospital with drunk relatives. And they'll come and do all the things. Yeah, so yeah, Brett. What's the way on Papa?
All right, you watching Cafdil on Cafdil television. I'll go for a short break. When we come back, we're going to talk about their increasing safety concerns and what we can do to protect themselves. Stay with us. I'll be right back after the break there.
Thank you.
Since time immemorial, God has always communicated himself and his will through various voices: the prophets, the kings, the judges, not forgetting John the Baptist, who was a precursor to Jesus Christ and gave us the will of God. We bring to you Voices from the Valley. This is a program designed by the Conventual Franciscan Friars in Ghana in collaboration with Cafdil TV to bring you in-depth insight in our faith, catechesis, and various Catholic teachings which will help you in your journey as a pilgrim. I know you cannot miss this program, and I highly encourage you that you shouldn't miss this program because it is Voices of God from the valley of prayer and silence. Join us this and every Sunday at 3 p.m. and a repeat on Wednesday at 7:30 p.m. here on Cafdil TV and on our various social media platforms: YouTube, Cafdil EDU, and Facebook, Cafdil Cape Coast. Let us meet and share what God has for us through the Voices from the Valley.
Make me a means of your peace.
Welcome back to Cafdil on Cafdil Television, and we are still discussing World Emergency Medicine Day. I'm here with doctors and nurses. Doctors and nurses, you know. Yeah, sure. Today I'm learning a lot. And I hope you're also learning a lot. We are live on Facebook and also on YouTube. Facebook is Cafdil Cape Coast, and YouTube is Cafdil EDU, Cafdil Edu. Yeah. So like and share and leave your comments. Certainly we will read them at the appropriate time for you. Before we went for this breather, you were saying something, but I want to I want you to continue from here. Like around the world, the whole world, you know, health workers, especially you, those are the emergency, facing increasing safety concerns. What's actually happening?
Okay. So what the picture now is like, my earlier submission, I said that when you have a relative who is involved, whether sick, involved in an accident, you become so anxious and you want the person to get the safest care or the best care. So you rush, you come there with that kind of this thing. But we have limited space. So imagine, let's say you have one patient we are attending to and about 5 or 6 relatives are on you. And you are wasting time telling them, please, can you go outside so that we can attend to this patient? And they are telling you that, oh, do this, do that. In the midst of doing the forth and back with them, because you are a human being, you keep repeatedly, if you say that, oh, can you step aside so that we can have access to the patient and care for the patient? And it's like, at a point, somebody will be like, no, I am not going. So it may create some kind of tension between you, and it's also a waste of time. In emergency, we say time is muscle. In fact, we don't have that time. It's a very fast-paced environment. So in the flip of this thing, things are changing, and so we don't have that time to come and have that forth and back with you because somebody is dying. We need to attend to that patient. So when we talk about that safety, we want you to give us, believe in us, trust us, that you have brought your relative and that person will get the best of care. Right. So give us that space, and at the same time we also want you to respect us, that we are also human beings just like you. You want me to respect you, you also have to respect me. And whilst we are doing that, it is also transforming in our emotional well-being. It also affects us positively, because if you go through this wear and tear, the baby, forth and back, troubles here and there, it has effect on us as a professional. So we go through that wear and tear. With time you come, what you were expecting, that smiling face that you were expecting, you won't get it again.
So you also have your own issues
Yes.
to deal with.
We won't get it again. So they should give us that safe environment so that we'll be able to give them the best of care that they need.
Dr. Matilda,
Yes.
you made mention of triage.
Yes.
It's one term that we hear in emergency departments. So explain to us, for us to understand the triage. What exactly does that mean?
Okay, so when we say triage, it's a scale, okay, for sorting. When you say triage, it's basically sorting. But what are we sorting? We are sorting the most critically ill from the less critically ill to be able to attend to them. And when we say triage, we have it in the categories of red, which is, the maximum. That's life-threatening emergency. Then we come down to orange, which means that we can see you in a few minutes, possibly 10 to 15 minutes. We have to attend to you. And we have yellow, okay, and then green. So yellow, within an hour or two, we should attend to you. And green, possibly, you're fine. You can go to OPD. That's where somebody will come and it's an emergency, but you triage and it's green. And when you say, okay, I think you have to go to the polyclinic so we can attend to from yellow to red, then somebody gets angry that mine was also an emergency. But the standard, the scale has proven to us that, it works. So that is basically what triaging is, sorting the life-threatening to the less life-threatening, and then managing them in that time frame. Notwithstanding, people can switch from yellow to orange. Human dynamics, we can't really tell. But even though we also know that you can switch. So we also pay attention to you. Do you understand? But with the green, we know that you can stay a longer time. So why not go to the OPD to be attended to early? So that's basically what triaging, or what we say sorting, is about.
So does that mean that some lives are more important than others?
No.
The triage?
No.
Going by that.
So what that actually means is that some people are at more risk of dying than others. And so if in our environment where our resources are limited, we don't want to spend time doing what is not going to improve life. So if you have small resources, let's concentrate it on those who require more resources. So if you use all your resources on those who don't require more resources, when it comes to the guy who needs more resources and he has run out of the resources, then it's certain death you are going to deal with.
So then how are you able to decide who needs immediate attention?
Based on triage. So it's a science we are using to work in the hospital. It has nothing to do with your money, has nothing to do with whether you call CEO or you call some minister, or that doesn't affect how your triage color is going to be. The triage, we use your heart rate, your blood pressure, your glucose level, your oxygen level, and we do a calculation called a TU calculation. That will give us some number, and that number will correspond to a particular color which has been verified to be true. So if we say that you scored red, then we must see immediately. It is true that if you don't see immediately, you're going to die. The same way it is true in that extreme, if we tell you that we scored green and that you can wait for 4 hours, it's similarly true that if for some reason we don't see you within 4 hours, your vitals will not deteriorate so bad to make you be in danger. And that's how we want to be able to see our patient. We don't see our patient based on CEO has called to see my friend is coming. That's not how things work. The first thing you do when you come to our hospital is that you'll be triaged. And based on your triage, we'll decide on whether to speak to you or not. Luckily, there's a place called in our triaging called the Senior Healthcare Professional Discretion. Someone can come to you scored yellow, but based on the experience of the nurse or the doctor who is seeing like, although this guy has scored maybe say green, we think you should go to the OPD. Based on my experience on seeing this patient, I think that we should up triage him to a higher color so that we can see him at the emergency department. And that decision is discussed between the doctor on duty and the nurse who's there trying to agree that, this guy appears to be very good based on the numbers you're calculating. Let's try and bring him up and we'll sort him out. So for example, this morning, someone comes to the emergency this morning, scored green, we are saying go to the OPD. There's no argument about that. But then we also say that, because the leg is swollen, we think there might be a clot in the leg, so let's uptriage him to yellow so that we can have some emergency assessment of the leg so that he can be safe. Otherwise, so all we are trying to do at all point in time is to bring the guy who is sickest closest to the doctor. So there's a queue of sick people. The sickest gets closer to the doctor, and the one who we think is not sick will be furthest away from the doctor. And even if it's almost time for you to see the doctor, and someone else comes in who is scoring red or higher, they're going to bypass you. And this person who is waiting will be like, I came first, and why have you bypassed me? So it has nothing to do with you came first. It has everything to do with who is dying now. The person who is dying now will see the doctor soon. And you will tell me that, oh, I'm also dying now. How you know? And based on what scale are you able to do that? You are doing emotions, we are doing science. And you should trust that because our mortality rate is 3%. We might be doing something right. We might know exactly what you are doing.
You do all these things. So why do misunderstanding about trial sometimes lead to frustration or conflict in the emergency department?
I will leave it for them, and I think it's generally perception based.
Yes. So, I mean, like we've said, the patient's perspective about emergency, okay, and our perspective about emergency. You may come in, we'll check you. I wanted to like break it down to layman's terms so that we can understand what we are saying. With the triaging, okay, we've said that it's a skill. It's a skill. There are certain symptoms that you mention. It will ring a red flag in my mind. And those symptoms are on a long sheet. So when you come and you say this particular symptom, for example, you say my chest, and it's an elderly person. Okay. Whatever I'm doing, you get it. I'll stop and then let somebody will try. Immediately you come and say my chest, you're elderly. It is straight orange. I mean, I have to see red. You. It could even be red. Okay. But with that, now we'll check your BP, check your pulse. Then we know that this is changing. This is not a normal BP. This is not a normal pulse. His breathing is not normal. And all these things already, when he said my chest from afar, it was orange. And then he has come in and put the BP cuff and things. And now the person has shifted to red. Do you get it? Because of all the things that we check. But when we check your BP, you can be shouting. We check your BP and normal. Your pulse and normal. Temperature, normal. You're shouting. You get it? So we'll check all these things. Your body will not lie to us. You understand? Another is seizure. Oba, what's wakan? Oh, jinadu gidigidi. That is red. That is straight red. According to us. So it's not just about talking about skill. List nyamubu ha. Eba, we know that, okay, this person is this person is that. But now you don't fall in the criteria. We will still go ahead, check your vitals, temperature, BBR. There's our calculus. Only there. It is not an emergency, or it is an emergency. Let's attend to you immediately. So we want people to understand that there's a skill, and this is how it is like. So when we say that we have to attend to someone else, please understand us. And then wait for us to finish with the dying patient and attend to. Definitely will attend to you per the skill.
Our time is drawing closer. So let me come to you, Mrs. What is EMSOG?
EMSOG. Emergency Medicine Society of Ghana.
Oh, okay. So what solution do they recommend to improve emergency care and protect both patients and providers?
Yeah, so I think I've mentioned quite a number about our safe space, and we've also talked about respecting us, and so that we also give you the respect back. We also talked about our resources. Yes, generally in Ghana, the emergency care is not the up, but we are not bad. Either.
Since
but
CCT has reduced the mortality rate.
Yes,
3%,
yes, it is really a plus. Yeah. Though we still, Oliver Twist, we still need more of those resources that we are talking about. Then we also need our security. The security, so this space and the security will go together. Though we have security there, the security will also come from our stakeholders, patients and patient relatives who also come to the unit. So that's one thing that we are all asking our people, our stakeholders to do for us when they come to the emergency. And also they need to also, like the triaging that we are talking about, they need to understand the processes that goes on. Definitely you won't come and expect us to explain triaging to you when you come and you are having your abdominal pains. Nothing triage multi. No. We will take care of you. But once we are doing it, if something comes and it is higher than yours, and we take care of that one, definitely there's going to be calmness. When there's calmness, which is usually brief, we don't have calmness for a long time. We can't have calmness in the A&E for more than an hour. It is not possible.
We always feel something is wrong somewhere.
Something is wrong somewhere.
We love the chaos.
We always so it's like we may have definitely about 10 minutes. There could be calmness. We can use the opportunity to also educate our patients, our patient relatives who are there about some of the things that we do there, because triaging is ongoing. It's not something that is an event. We do it once a while. It stops. It keeps revolving like that.
I wanted to know, look, so if you don't explain, when you give them the color or whatever, and you don't explain to them for them to understand, certainly there will be a...
Oh, we do. Most especially for the red cases, the orange cases, we don't have much of a problem with them. But it's between the yellow post, sometimes you don't, but the green cases.
Those who are not emergencies.
Emergencies.
Yes.
Those who are talking plenty are the ones who are safe and can wait, but then the ones who
we'll give you an example. Somebody went to the farm. He said he went to the farm and he believes that no scorpion. But you're checking after doing the triaging and everything. He scored green. So we asked, where do you think you had a sting? Also, so sure. So we examined, thinking that we'll see maybe bruises or something. There was nothing. Does it pain you? No. Do you feel anything? No. BBR? No. Then it's okay. Then I think you should go to the polyclinic so that obia scorpion na come then I'm go polyclinic. Okay, no problem. So you go to polyclinic. Let's wait for about an hour and continue to examine you and see, like we'll continue to assess you and see if there is going to be any change. He sat for 1 hour. He got furious. Why? What's not such? Because scorpion na can, and we are not doing and we are not doing anything. Yes, and we are not doing anything for him. Oh yes, I think yes. I think it will help. You can even just come and sit at the security gate and just be turning and observing what is going on, and it's not easy. I think a few minutes ago somebody shared one experience we had at the emergency where somebody was scammed. We was called that the son is bleeding and they need blood transfusion, blah 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 and all that, and they need 3,000 Ghana cedis to be able to get the son the blood type that he needs. And this man, whilst he was coming from the room, when he just entered badging, started insulting everybody. Then as and then doctor no so and all that. And when he was doing, because he was very furious, nobody could control him. After some minutes, then somebody approached him, and when we interrogated him, we realized that he was being scammed.
It's coming. What ambulance?
Because ambulance, you know. Yes. And so when you realize he was scammed,
no. One parent. I mean, you understand?
Yeah.
From say what hospital. What's it? We hear them.
Yeah. Oh, it happens. People are coming for Obi to me free Kumase Kraba. was Kanobi of Kumasi or back Cape Coast Teaching Hospital.
Sometimes I don't.
Yeah,
If
so
you have a ward in school, you have teachers, you have their numbers. If there's a situation like this, certainly the teacher, housemaster, or whoever will call you. Why don't you? If they don't call you, why don't you also call?
The way they will say it, the way they will say it before you have time to think, now why it's too late. But I remember one doctor even called me that Doctor. Why you never ask me when you go to bed and get into me fast? I'm going to find a betting. So me from a card, mudu me share me you.
You power from.
You come in, why doctor? From them, that be. Doctor now from the when you call there never asthma attack. This is when I got to Bedingate. To Mukona for number and Tibet they say by all means on ya to me fast mudu shape or he
was not there.
Go chair na
Anyway, we are going. So let me start from you. What you are marking this emergency medicine, a world emergency medicine day. So what message do you have for our viewers?
Oh, so we want to tell our stakeholders, basically our patients and patients' relatives, that they should try and have patience for us. When they do have patience for us, the care that they are looking for, they will get it at the maximum, unadulterated. So we want them to have that patience for us, trust us, believe in all that we are doing for them.
Matilda.
Yes. So, I mean, my word for the public, is that they should be patient with us, and they should understand the whole trial. Exactly. It will give us that space to be able to attend to patients. They should trust us that we will actually do our best for their relatives.
What I want the patient and our people to know is that we are working in a very chaotic environment, and we do that every single day, 24/7. The least thing we want is extra
distraction,
stress. The extra stress would mean, just like she mentioned, someone come from the house without asking questions, abuse, fighting with security man, fighting and demanding your right. We are inside the field. It's not a so perfect field, but we know the terrain. So like she said, trust that when you come to hospital, trust that you have come to us, and allow us to pull you out of whatever danger you perceive yourself to be inside. We admit that sometimes what you perceive to be emergency may be very different from what we think emergency is. And so when we give you that information, trust us. The same way you will trust us when we say you are red, so we should see you now. Trust us when we tell you that you are green, you should go to OPD.
Looking at your situation, certainly you need more nurses, more doctors at that particular department. A lot of people, because of the stress, a lot of people, I don't foresee people coming there like that. I mean, people wanting to be in that department.
Oh, I see you are there. People who are in want to leave because the work is very difficult. But some of us too, this is what makes us, we are happy to be in the chaos.
If you know, when Jesus Christ was in there,
when Jesus Christ was in there, I have not gone on leave for a very long time. But we don't talk about this one. It's our own decision. No, when Jesus Christ was on the boat and everybody was blah blah, he came and said, "Peace be still." That's exactly how we feel when we're in the emergency department. When everything is going chaotically, we want to be there to come and tell you that, calm down. We've got this.
All right. Thanks for coming. I appreciate your presence. This very time will allow us to be with you. And you heard Pastor Doctor. Pastor Dr. Papa Kujo Mbro is the emergency medicine specialist and also head of department of emergency department, Cape Coast Teaching Hospital. Dr. Matilda Emisa, medical officer, emergency units, and Mrs. Evelyn Bawa Aisen Arthur, so emergency nurse specialist, Cape Coast Teaching Hospital. Thanks for watching. My name is Kujo Arthur. Same time next week. Shalom.
Sorba moji bijezi Mojo.